All right. So I think we're going to go ahead and get started. My name is Ben Prince. I am actually one of the attending allergist immunologists over at Nationwide Children's Hospital in Columbus, Ohio. And I know many of you. I know that I'm kind of maybe unfamiliar to these presentations. Unfortunately, I think they typically take place on Thursdays when I'm in the midst of a busy clinic. So I appreciate the flexibility in allowing us to move today's meeting over to Tuesday so that we could share some interesting cases with you guys and hopefully have a really good discussion. I have the really privilege of introducing a couple of my favorite people. The first is she's listed as Dr. Emily Engelhardt, but I will let the cat out of the bag. She actually just recently got married and changed her name, so she is now officially Dr. Quartermain, but we left it as is for the sake of this presentation. She is actually one of our second year now fellows. Who's fantastic. We actually had the privilege of recruiting her out of our residency program at Nationwide Children's Hospital. And so she has actually been involved with the care of two of the patients that she's going to share with you today. And then it is truly an honor and privilege to introduce Dr. Roshini Abraham. I think if you don't know who she is, you're probably living under a rock for the last decade. But we have the really amazing honor to work with her. She's the director of our diagnostic immunology lab, and a lot of the diagnostic functional testing that we're going to be sharing with you today, she developed. And so we're happy to allow her to be here too and have her here as the invited guest expert. So with that, we will not delay any further. Dr. Cornway, I'll turn things over to you.
Perfect. Thank you so much. Our topic today is titled Slinking Under the Radar, Functional Assessment of Hypomorphic Variants in X-linked Agammaglobulinemia, or XLA. So our objectives today, we're going to discuss the phenotypic and genotypic spectrum of XLA, specifically with regard to BTK variants. We'll also describe the role of assessing BTK protein and function in patients that have hypomorphic variants in BTK. So we'll first start off with a case. We have three pairs of patients. I'll try to remind throughout the presentation, but patients 1 and 2 are a pair of brothers, a 7-year-old brother and then an almost 2-year-old brother. So the 7-year-old, he initially presented to immunology clinic. He presented with poor growth. He had recurrent sinus infections, recurrent ear infections that required 4 sets of ear tubes and needed 10 lifetime courses of antibiotics. His younger brother, who presented shortly after he did, also had a history of bacterial pneumonia that required an admission and also had recurrent ear infections as well. Their family history was notable for a maternal great uncle who did pass away from encephalitis after receiving his polio vaccine, but they did not have any history of viral or fungal infections at the time of presentation. Patients 3 and 4 are a mother and son pair. So the mother was 47 years old when she presented with recurrent sinus infections and she had a history of cryptococcal meningitis. Her 19-year-old son had autism, ADHD, allergic rhinitis. He also had some recurrent sinus infections as well as oral ulcers at the time of his presentation. And then the last pair of patients are, again, brothers, patients 5 and 6. This was a 3-year-old and 5-year-old pair of brothers. The younger brother had a history of recurrent ear infections, as well as pneumococcal pneumonia that was complicated by parapneumonic effusions, and as well as bacteremia. And his older brother had a history of several viral infections, as well as ear infections, also had a pneumonia and a pleural effusion. So I know we already gave away the diagnosis here in our title, but we were hoping just to get some audience participation on what your differential would be, how you would start to work up these patients if you saw them in clinic.
So I'll jump in and just give you a little bit of audience
Okay.
participation, Emily.
Sounds
So I think the things that stand out in these patients, and all of them are, kind of sinopulmonary infections, potentially encapsulated bacterial infections. And so that certainly raises some suspicion for, an underlying humoral immune deficiency. Another thing, the way I think about that too is obviously immune deficiency is rare, although maybe not as rare as we thought maybe a decade ago. But antibody deficiency is also certainly the more common of the rare. So I think that would certainly be on my differential given that presentation.
Yeah, great. Some things we had thought up on the differential, CVID would come to mind, possibly like a hyper IgM syndrome, autosomal recessive agammaglobulinemia or XLA. Those are some things that were on the differential. So going through patients 1 and 2, again, this patient 1 was the 7-year-old and patient 2 was the almost 2-year-old brothers. When looking at their initial T cell, B cell, NK cell values, their absolute number of B cells were 22 and 25, so only made up 1% of their lymphocytes. And then looking at their immunoglobulins, their IgG was significantly low, IgA and IgM, some of those being undetectable. And then really their response when checking for diphtheria, tetanus, and pneumococcal responses were really suboptimal for the majority of the vaccine titers that were checked. Their T cells, absolute counts were within normal limits. So really this was more of a B cells and their immunoglobulins that were low. Moving on to 3 and 4. So again, patient 3 was the 47-year-old female. Her laboratory evaluation, which we'll get into a little bit later, but she did have a CD4 T cell lymphopenia with an absolute count of 49. Her B cells were also low. Her IgG was slightly low at 540 and her IgM was low at 25. And again, did not have a response after receiving Pneumovax. Interestingly, her 19-year-old son actually did have a pretty normal workup when it came to looking at his absolute number of T cells, B cells, NK cells, and then his immunoglobulins as well. And then patients 5 and 6, these were the 3 and 5-year-old brothers. For both of them, they both had a significantly reduced amount of absolute B cells with 20 and 4. And then again, their IgG was low for both patients. IgA was actually undetectable for both of them, and then low IgM for both of them. And again, their tetanus, diphtheria, and pneumococcal vaccine responses were definitely suboptimal. So with that, if anybody, I'll give a second if anybody has any other ideas on how you would proceed from here in clinic if this was your initial workup.
So I think that I think the interesting thing here that maybe has changed over the last 5 to 7 years is I think that clearly there's a profound defect in humoral immunity here for sure. Maybe more of a combined defect in the mother, and I think what's changed at least in the last, you know, 5 to 7 years is I think we have the access to much more rapid genetic testing, right? So I think the early presentation of these kids, the fact that they have a clear, it's not arguable, like they clear pretty profound humoral immune deficiency. There is certainly a high suspicion for an underlying inborn error of immunity. And then the other thing to point out is, there is some, although it wasn't completely clear, but some family history there as well that maybe raises some suspicion for some inborn error of immunity. But I think it's always, last thing I'll say is I think it's always interesting to have a conversation. Do you just jump right to genetic testing, which I think a lot of us do, especially in the situation when it really is out, stands out, versus doing more immunophenotyping, doing more functional testing. So I think you could go either direction.
We had talked about doing further immunophenotyping, looking at especially their B cells further, but for the sake of this talk, we're gonna jump to their genetic testing. So all 6 of these patients had genetic testing performed. Patients 1 had the same intronic hemizygous VUS and BTK. Patients 3 and 4 also had the same VUS and BTK. And then patients 5 and 6, again, had an intronic hemizygous VUS and BTK. Patient 5 had an additional variant, but that was a synonymous variant, so should not impact the protein. And these will be repeated in the next slides. We'll go into the variants here. So again, to go into these to dive into the clinical significance of these variants of uncertain significance, we were talking through kind of an initial evaluation of what you can do when when a result is a VUS, wondering if this could be clinically relevant. So one of the first things to do is to consider the allelic frequency in healthy controls. So this can be found on databases like Nomad. So looking if the variant is present in a lot of healthy controls, it's unlikely to be pathogenic. Has it been reported in individuals with disease? This could be on PubMed or ClinVar or ClinGen. And then using in silico predictive tools, which we'll dive into a little bit more here, as well as in vitro functional testing, if that is available. So going into the variant information, again, for patients 1 and 2, they both had a intronic hemizygous variant, VUS, in BTK. This variant was not present in Nomad, not previously published in PubMed, not present in ClinVar, but it was predicted to affect splicing by in silico methods. As you can see on the right there, 2 of the methods were near 100% predicted to affect splicing. And then the American College of Medical Genetics score was a 2 for this variant, categorizing it more as a VUS. So based on this variant information that we have in the literature, unclear, and we can't really draw conclusions whether or not this is a pathogenic variant. Patients 3 and 4, in Nomad, their allelic frequency was very, very low, as you can see in the percentages there, making it less likely that, or more likely that this could be pathogenic since it's not present in a lot of healthy individuals. Again, this was not previously published. However, in ClinVar, there were 2 VUS submissions in patients with Agammaglobulinemia, so that would fit the phenotypes that we were looking at. And then using the in silico predictive measures, the CAS score was 27.1. If this score ranges from 1 to 99, but if the score is above 20, that puts you in like the top 1% of being likely to be deleterious if there is a variant there. The Revel score and the Eve score both range from 0 to 1. The closer to 1, the more likely it is to be pathogenic. The ACMG score for this was 5. There were a few predictors that were moderate, 1 pathogenic, but still not able to clearly say that this variant is pathogenic in nature. And then patients 5 and 6, again, this variant was not present in Nomad, not previously published and not present in ClinVar. However, the in silico testing was actually not predicted to affect splicing. This variant was actually between exons 14 and 15. 1567 is the first coding nucleotide of exon 15. So then, again, we haven't drawn too many conclusions by looking at the variant information. So now moving on to how we could functionally assess these variants to see if there's any functional defects that could point us in the direction. So about 90% of patients with XLA will have absent or reduced BTK protein expression, but assessment of BTK protein expression by flow cytometry can serve as a functional assessment of BTK variants. So Dr. Abraham is able to do this in her lab. So the figure 1A, she gated the cells for CD19 positive B cells. Figure 1B is for CD14 positive monocytes. So when thinking about BTK, it's present in our B cells, monocytes, and platelets are the main cells it's present in. So when looking at figure 1A, this is looking at the median BTK delta median fluorescence intensity. And as you can see for the healthy controls, the presence of the protein the MFI is much higher than for patients 1 to 6. All of them fall below the 5th percentile. And the same holds true for the CD14 positive monocytes as well. Patients 1 through 6 were all below the 5th percentile for the median fluorescence intensity. So now just taking some time to review B cell development in general, starting in the bone marrow. Just an overview when thinking about BTK, we think of this as an issue moving from your pro-B cell to your pre-B cell. So starting at the top of the figure, this pro-B cell is CD19 positive. Again, outside what we're talking about today, but ARA or autosomal recessive agammaglobulinemia can be related to defects with the mu heavy chain, the surrogate light chain, CD79A, CD79B, which help with signaling, or blink. Those are more commonly associated with autosomal recessive agammaglobulinemia, or X-linked agammaglobulinemia. The BTK protein is what is impacted. So again, there's an issue going from the pro-B cell to the pre-B cell, as seen there. And those beginning stages are all antigen-independent stages. And then on the right-hand side of this, we're moving to more antigen-dependent stages, looking at the immature B cell and the mature B cell. So this, again, is all in the bone marrow. And then moving to the periphery, the mature B cell will then leave the bone marrow and enter the secondary lymphoid organs. This would include lymph nodes or tonsils, where they can undergo somatic hypermutation and class switch recombination. There are some other switch memory B cell defects that we won't dive into too much during this talk, but some other things to think about would be a defect with CD19, CD20, or ICOS could be related to CVID, or CD40 ligand or CD40 can be seen in hyper IgM defects. But eventually, as seen on the right, it's class switching, so you can go from IgM to A, G, or E. And this is all more antigen-dependent stages as well. And then this slide shows an overview of the BTK and B cell signaling. So on the surface of the cell, there's the B cell receptor that recognizes the antigen, and then they're signaling through Lin, Sic, and Blink that signal through BTK, which eventually, through several different pathways, including NFAT, NF-kappa B, and ERK, lead to activation of transcription. So this is actually what the BTK protein itself looks like. There are 5 different domains. So starting on the N-terminal side, there's the pH domain. Moving next to the TH domain, an SH3 domain that has the Y223 site of autophosphorylation, the SH2 domain, and then the kinase domain, which is also known as the SH1 domain, which has the Y551 region on it that is actually phosphorylated. So the majority of variants in BTK are going to be in the kinase or SH1 domain, and the majority of these are related to missense variants. There have actually both this Y223 and Y551 areas for phosphorylation are both like critical to BTK function, and they are like the two key residues for phosphorylation. But it's important, which we'll highlight this later, but it's important if using an antibody to detect an epitope on the protein, if your epitope is in this region near the N-terminal and you're detecting that area, you could detect the protein, but if your defect is down more on like the C-terminal, you might be detecting the protein, but it might not be functional. So looking at BTK protein expression does not measure the function of the protein, and the sensitivity is also affected by, like I had mentioned, the antibody used depending on where that epitope is on the BTK protein. So then the next step in functional assessment would be to look at the BTK protein phosphorylation, again by flow cytometry, can be another way. And again, Dr. Abraham is able to perform this in her lab. So figure 2 is looking at the phosphorylation. So starting on the A side, we're looking at CD19 positive B cells. On the left-hand side, that's just the basal phosphorylation of BTK. And then the blue, a little bit to the right on figure 2A, is after stimulation with pervanidate, which is used in the lab to stimulate phosphorylation. As you can tell, for the healthy controls, the MFI, the median fluorescence intensity, is well above the 5th percentile, but for 5 out of our 6 patients, all of them except for patient 4, their median fluorescence intensity is well below the 5th percentile when stimulated with pervanidate. And then on the B side, the figure 2B, that's showing the delta MFI. Again, for 5 out of the 6 patients, it is below the 5th percentile. So diving into XLA some more and going through the presentation, overall, it affects about 1 in 100,000 to 1 in 200,000 live births, again, due to these pathogenic variants in Bruton's tyrosine kinase gene that results in impaired B cell differentiation, again, during B cell development. However, due to maternal IgG transfer during pregnancy, oftentimes patients don't present right after birth. A recent article had quoted that the average age of diagnosis in the US and Canada was 26 months of age. So again, they typically don't present right after birth just due to the maternal presence of IgG. Typically, infections involve, as seen in our patients, the upper and lower respiratory tract. And again, we think of encapsulated bacteria as causing these infections often. So this would include strep pneumo, Haemophilus influenza, are 2 of the main ones that we think about. They also have an increased susceptibility to enteroviral infections, so polio, Coxsackie virus, echovirus, which we will dive into a little bit more on the next slide explaining that. They can also have parasite-associated diarrhea, sepsis, meningitis, and encephalitis. Another lab abnormality that they can have is neutropenia. And then on exam, they can have hypoplasia of the tonsils, adenoids, and other lymphoid organs. So it makes sense from an antibody standpoint, if they're not producing the antibodies, that they would have an issue with some encapsulated organisms. But now diving into a little bit more about the virus, the predisposition to these viruses in XLA. So really, the highlight here is that BTK is crucial for TLR8 signaling. So TLR8, or toll-like receptor 8, recognizes single-stranded RNA viruses, such as the enteroviruses. And the BTK helps with TLR8 signaling. So if that is impacted, then the recognition by TLR8 is impaired. So this highlights diagnostic criteria that was actually presented back in a paper from 2006. We wanted to highlight here that now we do have some other functional testing, so we can make this diagnosis, in a couple other ways, but currently the criteria would be a BTK gene mutation or defective expression of BTK protein, or patients that have less than 2% peripheral B cells and hypogam, or patients that have a family history of a male relative on the maternal side with XLA. Oftentimes, we think of this diagnosis being made in young children, but this diagnosis does exist in adults, especially related to hypomorphic variants, as patients with a hypomorphic defect can present later in life, as they can have partially preserved B cell numbers and function. So overall, as an adult, XLA can often be misdiagnosed as CVID, but it is important to remember that only about 5% of CVID cases will have less than 1% peripheral CD19 positive B cells. So if a patient has very low B cells, it should be a flag going off that maybe this is an XLA or a hypomorphic XLA defect rather than CVID. And this is a nice flow algorithm looking at the evaluation of the adult patient with a humoral immunodeficiency. So oftentimes, as we had mentioned, these patients will have a history of recurrent cytopulmonary infections. It's important to consider the age of presentation, how long these infections have been going on, and what age they started having symptoms. If in your evaluation you have hypogammaglobulinemia with low G, A, and/or M, and absent functional antibody responses, it could lead down a CVID pathway, but it is important to remember that if a patient is male, has a family history of XLA, has absent or reduced B cells, or has hypoplasia of secondary lymphoid structures like lymph nodes or tonsils, it is important to make sure XLA is on the differential. So we'll go back to our patients, our pairs of patients. So patients 1 and 2, as a reminder, this was the 7-year-old and the almost 2-year-old brother. So during the workup for patient 1, who was the 7-year-old, while he was being worked up, he actually was admitted to the hospital for strep pneumobacteremia, thought it was likely seeded from bacterial sinusitis. For both brothers, subcutaneous immunoglobulin replacement therapy was started, which resulted in significant improvement in their sinopulmonary infections. Patient 3 was the 47-year-old female. She had more of a complicated course. She had cervical cancer that required chemotherapy and radiation that is now in remission, a DVT, polymyalgia rheumatica that had a good response to steroids. She was treated with SCIG initially, but didn't tolerate it, so was switched to IVIG. Currently, she's on fluconazole, trimethoprim sulfamethoxazole, anticoagulation, IVIG, and prednisone daily. I will say about her a little bit outside the scope of this talk, but she did have several other things going on, and she also was found to have a REL-A variant, which could explain that CD4 T cell lymphopenia that we saw initially. We just left it out of this talk, focusing more on the BTK variant. And then patient 4, her son, they were considering doing IgG replacement versus antibiotic prophylaxis due to his couple episodes of sinus infections. And then patients 5 and 6 were the 3 and 5-year-old brothers. They were both started on immunoglobulin replacement therapy, which resulted in clinical improvement. Does anybody have any other questions regarding the workup? We can start there if anybody has any clarifying questions. And then we were hoping for maybe some thoughts on whether or not this could be clinically significant for female patient 3, given that she is a female. And typically we think of XLA as X-linked in males. So she ended up having an X inactivation study performed that showed a skewed X inactivation pattern with a ratio of 89 to 11. It did not sort out between the BTK positive and negative monocytes. So the reported skewing is just from like a bulk analysis, not specific for BTK, but she did have this skewing with a ratio of 89 to 11, which makes us think that this could be clinically relevant in her situation. So looking at X chromosome inactivation in females, starting with panel A on the left, this depicts the main mechanism of X chromosome inactivation in females, which is a normal thing. One of the X chromosomes is randomly inactivated during early embryo development. And then the inactivation status is actually passed on to daughter cells. As patients age, though, this X inactivation can be skewed. This can be related to clonal hematopoiesis, depletion of hematopoietic stem cells, or selection pressure on leukocytes. But that's shown in panel A. And then panel B and C are showing more of the mosaicism through the loss of the X chromosome. And again, if there's this skewed X inactivation as seen in C, there can be more of an imbalance present. So there are several ways to assess for X chromosome inactivation. The first 3 ways listed here are methylation-sensitive PCR, quantitative methylation, specific PCR, and targeted sequencing. All rely on methylation methods to evaluate X chromosome inactivation. And then the last method, the RNA FISH, is focusing more at gene expression at an RNA level, the individual cell level. And then we just wanted to thank some of the other providers, Dr. Zimmerman, Dr. DiGiacomo, and Dr. Basu for providing some of these patients and also some of the help with the laboratory evaluations. So at this point, we'll take any questions or open to discussion more about this.
Thank you, Emily. That was a really, really great presentation. I will say that one of the most powerful tools that we've had more and more of these days, the two things I can think of. One is you talked a little bit about in silico testing, and I think that's something that's really come a long way over the last 5 years with advances in AI and some of the tools we have. I think we rely on those more and more. So, in 2 out of the 3 of these cases, it was very helpful, but you can see that it's not perfect. And so, um, you know, that's why, again, starting this talk, so thankful to being able to work with somebody that's able to just make up or design tests that can functionally validate different things based on pathways, immunologic pathways that are impacted. And I'm old. I'm not that old. I've been in my current role for about a decade. But when I trained in fellowship, we didn't have those things, and so we didn't even do a lot of genetic testing. So just to put in perspective of how far this has really come and how valuable some of these tools really are, not just available at Nationwide, but at diagnostic centers around the country and world. So, but fantastic talk. I think the other thing that I've learned just in the process of the last 10 years is how, not every textbook inborn error of immunity presents like it says it should, right? So thinking about variable expressivity and incomplete penetrance, and now more recently with monoallelic expression, it makes it very challenging when looking at genetic testing. And a lot of times I think I've been surprised when you get, send a genetic testing and get a result back, you oftentimes get possibilities that you didn't even have on your differential. And so I think it's also helped us learn a whole lot. I don't know, Dr. Abraham, do you have a couple of things you want to comment on?
Thanks so much, Emily, for putting that presentation together, and thank you, Ben, for having me. I think the sort of messages maybe that we want to summarize is what you already pointed out, Ben, that you've got the textbook presentation and then you've got versions of that. And I know at Mayo, we saw several adults with XLA diagnosed for the first time in their life in adulthood. And we've also seen pairs of grandfather, grandson from the maternal lineage. And the grandsons, who are obviously younger children, once the grandfather has been diagnosed and we start looking at the family, the grandsons often present earlier than their grandfathers did. So there appears to be a component of genetic anticipation. And the other thing that you mentioned, and I think Emily also mentioned, is, the reagents that we use for the flow assay. Some of them will look normal, but you might find a splice variant to something. So it's always good to marry things together, look at protein expression. And if your genomic DNA analysis draws a blank, then think about looking at cDNA, or in this case, you can also look at function. So it depends. You ought to sort of ask the question of the lab. If your phenotype is classic and the lab comes back and says normal BTK protein or the genomic DNA was negative, that happened to me once. The cDNA analysis has picked that up, when the gDNA and the antibody that I used to use in the past, because 10, 15 years ago we had one BTK antibody available for use. Now we've got our choice of recognizing different epitopes, colors, etc. And then the other one was the point you made about the X chromosome inactivation. A lot of people order that test but don't realize how it's done. And so when they get a report saying there's skewed lionization, they tend to think it automatically relates to their specific gene, but that's not a guarantee. And also the androgen receptor assay is not a perfect assay for detection of lionization. So it's always good for clinicians to know a little bit more about what they're ordering, why they're ordering it, and how it's being done. I mean, Ben, I'm obviously older than you, and there was a time when clinicians didn't need to know that, right? Or they thought whatever mumbo jumbo was happening in the lab, that was fine and thing. But I don't think that's possible in today's world. I think clinicians need to know a bit more about the test they're ordering and how it's performed and how that affects their interpretation. So thanks again, Emily and Ben. I really appreciate your presenting this case.
Thank you for all your help.
Yes, agreed. I'll say one final thing. Yeah, 100% echo. That's something that, so I was lucky enough to participate in the diagnostic summer school through the CIS a long time ago. And that was one thing that I took away from it, is you really have to understand the test that you're ordering, how it's being done, and what it's telling you. Because you can't if you don't understand that, and you don't know how it's run, or don't know why certain, how it applies to your patient, you can miss it completely. And then the other thing I'll say is, this was a really great concept to highlight in XLA, but I have had many patients that have truly a hypomorphic combined immune deficiency, or even hypomorphic SCID, that have slipped through the cracks and presented later on, gotten live vaccines, and so on and so forth. So just keeping in mind that this phenomenon is not just unique to this diagnosis. So if there's no other questions, I think we can probably close things down. I think Evelyn went ahead and put the CME information over in the chat. So if you guys want to click on that, you should be able to obtain CME for this presentation. And hope you guys have a good rest of your Tuesday.